So welcome to part 2 of our podcast. My guest is Denise Paradis. Denise is Executive Director of the New Brunswick Continuing Care Association. And, we've been sitting here talking to Denise, and I guess you start to realize that the nursing home sector is really a very different sector. It's challenging by the fact that every home is different. And people used to talk about, well, physically homes are different, some homes are newer and so on, but probably even more critical than that is the makeup of the audience in the home, makeup of the care, the resident.
Yes. Yeah.
Now, we've been talking about your incident reporting program. I guess a question I'd have, a curiosity one, is when you sit back and look at, for example, 2022,
Right.
What kind of things stood out when you looked at incidents across the nursing home sector? What
Right.
What kinds of incidents were people having? Is it still the back? Of course, anybody who's worked in the industry knows it's
Right.
soft tissue,
shoulders, neck,
still the
arms,
soft tissues.
100%. And I think that's really what shaped us in that we were not going to stick with status quo as far as training and ways that we were going to address soft tissue injuries, mainly because, like you said, 70% still remain of all our injuries are soft tissue injuries. And that's been for the industry since the beginning of time. So why have we not been able to address that? I would say 80% are of the classification of as resident attendant or PSW, depending on where you are. And that makes sense. They're right at the front lines. It's then followed by LPNs, would be the second one. But the other thing with resident attendants is they don't get as much education as the rest of them. So their thinking skills are more of task oriented. And sometimes we have to find training that says, hey, stop. And the other thing too is for years and years and years, everything focused on the resident. Like I've said before, a lot of people think that, our home is filled with really cute, frail, old 90-year-old women, that are so sweet. But I can tell you, if you were not a sweet person out in the community, you're not a sweet person when you come into the nursing home either. If you were a tough man out there and rough and tumble, you're going to be rough and tumble when you come through our walls as well. But where we really have shifted the thinking, we've now also included the worker in the assessment. So we always had assessments of the resident. So how is that resident feeling today? Do they seem aggravated? And we had implemented what was called gentle persuasive approaches. Okay. So that was specific to kind of the behavioral issues that we have. So I'm trying to put your sock on and you're trying to stop me from doing that. So we gave them assessment skills to say, you know what is the big deal of not wearing socks today if you don't want to wear socks today, and not putting on socks and saving those moments for things that were actual, life type issues. Like if you really needed cleaning up, we're going to clean you up, but we'll try and find a better way of doing it and maybe have you participate in that. So that is some of the stuff that came through loud and clear from the incident management system. So it really has now shaped our focus in the last 3 years that we need to redesign what nursing homes look like and how we work, because we're never going to eliminate these incidences that are occurring otherwise. So now it's no longer just how is the resident today, but it's also looking at myself and saying, I had a rough weekend or I pulled my back muscle on the weekend. I'm not going to risk using my body to move another body. I'm going to use a piece of equipment today, even though normally I wouldn't with this resident. So there's a whole different way of thinking of it, because the statistics were the same over and over. We're essentially the most dangerous place to work in Canada, a nursing home. We have more injuries than any other sector.
Now, talk a little more about your gentle persuasive approach. Where did you get that? How do the staff find it's working?
Right. So gentle persuasive approach is out of Ontario. was created by gerontological nurses. I'm on the advisory committee, the National Advisory Committee, so now it takes information from everywhere. And the idea was just that we no longer wrestled people in bed to put their compression socks on today, that we really could foresee things that happen. So for instance, if there's a Mr. Smith, and I know he's a real handsy fella, he was handsy out in the community, he's going to be handsy in our nursing home. I now know what I used to do was I'd just go in and try and put his shirt on and just maybe tolerate being pinched or whatever it was. But now through gentle persuasive approach, we've given you some tools. I already know that Mr. Smith is handsy. I'm not just finding that out for the first time because this is the first time. We've got it written down somewhere. I'm educated on the person. I kind of know what their triggers are. But I might hand Mr. Smith a face cloth or a bowl of water and get him involved in the care. So now his hands are busy and I can go about doing what I have to do. During COVID, you could imagine with Alzheimer's trying to get swabs in people's noses. And, the thought, Marjorie and I, the thought of us holding somebody's head still while we did that, we just couldn't bring ourselves to that. And so we ended up asking, now, of course, we weren't doing the PCR test, we were doing the rapid test. We didn't have to get as far up the nose as anybody else. But we forget that there are still people in there. And so even though they didn't know who we were, and of course we're in masks, and they were starting to resist, it just dawned on us, why don't we ask them to do it themselves? And guess what? We got our samples by allowing them to do it. So gentle persuasive approach has taught us those approaches where we have forgotten, we almost emphasize people. We forgot that there are humans amongst that. So gentle persuasive gives me the techniques to bring someone to become more cooperative, or for me not to force certain things on them.
COVID must have been very challenging.
Oh, yes.
For nursing homes.
Yeah.
To deal with those kinds of issues.
Yes.
With the kinds of patients.
Well, it was even worse not having families involved. So with gentle persuasive approach really had to come into play because people didn't understand why so at first when we were having, the first time when we could let people back in, their families back in, it had to be in an open area where we could wash down the chairs. And the public health said that people had to be 6 feet apart. They couldn't touch. So you can imagine having a loved one with dementia sees their daughter that they haven't seen in months because we had been shut down, and not able to hug that person, not able to talk because we had to schedule everybody in. We had to leave time for everybody to be able to visit a loved one. So what we would call the amount of violence that ensued after a loved one walked out of a nursing home because that person couldn't express themselves, their frustration and their sadness in any other way than lashing out towards staff or items or any of that kind of stuff, was something that we didn't even anticipate. Yeah. That level. It was something else.
It had to be heartbreaking working in a home during COVID.
Absolutely.
I mean, we all, I think anyone you talk to was affected by COVID in various ways.
Yeah.
But I remember when we were going through COVID, thinking about, those poor people in the homes.
Yeah.
They, they don't get a lot of visitors anyway. The family hasn't been allowed to be in.
Yeah.
It had to make it so tough. Had to make it so tough on the staff too.
Yeah, the first place we went to, Marjorie and I, during an outbreak to go and help, the day we arrived, one of their coworkers had died of COVID. They were one of the first. We also had several residents that had passed away that we had to prepare their bodies. And of course, nobody knows, but the funeral home was backing up because the whole community was in trouble. So bodies tended to stay in the nursing home longer. The one case I can tell you that really sits in my mind is somebody who had their faculties with them. And we had to tell him he had COVID, and he understood what COVID was. And his family was in Ontario, so he thought he was going to die and never see his family again. And it was heartbreaking for both Marjorie and I. And I remember saying to him, I see you're religious, and you can't bring your stuff into the COVID unit because you don't get it back when you come out. And so I said, I see you're religious. I said, I will buy you a new Bible if we'll sneak this in under your covers and so that you can have comfort while you're in there, and I will buy you a new one when you come out. I said, I have faith you're coming out, and we'll have a Bible waiting for you here. And he was sure to tell me which Bible that would be that I needed to get. And I can tell you that the Lighthouse here in Fredericton gave me one for free when they heard the thing. So it was wonderful. But anyways,
very nice.
Long story short, he came out. But when we told him what he had, he wept. We sang Amazing Grace together. I mean, the nursing staff were weeping. He was weeping. We were weeping. My tough old Marjorie was weeping. But that'll affect us all the time. But the mentality of that for the staff on a daily basis, these are people that, yes, we're used to having death in a nursing home, but we're not used to 11 people dying at once. And we're not used to the first one that had passed away resident-wise was only 54 years old. I mean, it was, and very vibrant resident. So it was a really hard on the staff. And I think we're really feeling the effects now, actually, with the mental health and the physical exhaustion as well.
Now, was there help provided to the staff after that to deal with those?
Yes,
situations?
Actually, when the staff member passed away, we actually the home actually brought a team in at that moment. Good. And had everybody go through the EFAP team, like the emergency team, and then they continued after they were out of outbreak. Yeah.
I bet that wasn't in your job description when you accepted it, was it?
It was not.
Wow.
Yeah, it certainly wasn't,
So
and nobody would ever expect it. Yeah. And what was funny was I remember when I had heard COVID sort of in the background, and I had turned to Marjorie and I said, COVID, I said, is that something the Safety Association's going to have to get involved in any way? Like, should we be preparing anything? And she says, no, it's a public health thing. We were knee deep in supplies and going to the front lines and testing and all of that kind of stuff. It was incredible. Yeah. And kudos to all the staff that worked through it, really. And the communities too, because it was extremely hard on families.
Oh, yeah. It's hard on both.
Yes.
No ifs, ands, or buts.
Yes.
Hard on the patient, but when mom or dad or uncle or aunt so-and-so's in the nursing home, and you can't get in to see them, and they have COVID or... Yeah,
we had a family standing outside the window, and it couldn't have been rainier or windier every single day, and they're standing in front of the big window watching their loved one die, which was exactly what was happening. It was...
That's
heartbreaking. Yeah. And images you're never going to get rid of either. Yeah, as long as you live. So it's quite a different atmosphere to go. But what I can say is, until we did come to the front lines, so we did a whole PPE and what PPE, because everybody was worried, why don't we have N95s and why don't we, and you really don't need them. We didn't get COVID. If you had a face shield and a medical mask something to cover your clothing, it was perfectly fine. But because Marjorie and I were there, other homes where we weren't able to go to had even more severe staff shortages because they were terrified to come in, and they were even more terrified to bring it home. So every single day we were doing huddles, even on the wings that didn't have COVID, and answered every single question they needed answered, and lived by what we were giving them as advice. So if we told them they didn't need an N95, Marjorie and I were not wearing an N95. We were wearing whatever they're wearing, and then we could say to them, look, do you think we're going to put ourselves in danger? You can trust us. So they had all their staff came back when they heard we were there, every single one of them except for one that worked in utility. So that was a single dad, I think. So he was really worried about, the effects. We talked to him several times, but some people's fears are some people's fears, and you can't, but at least the home had all their staff come back. When we arrived, they had like 2 staff on on one wing. That was all that would come in. So it was great. We put in the testing, and they trusted us a
Many
lot.
years ago, before the pandemic and before COVID, I sat through a presentation that was talking about this kind of thing happening.
Right.
And I remember, when some of the things you've said, like, for example, they talked in the presentation about morgues would be backed up.
That's right.
That you would have freezer trucks
That's right.
parked by. They talked about issues like this, as I said, that the staffing would be a big one.
Yeah.
Because, yes, it wasn't necessarily people say, well, maybe only one or two people have COVID, so everyone else will be coming in. And they were saying, no, that's the
right.
problem.
That's
as you
right.
just said.
That's
that
right.
The other people wouldn't come in.
That's
and
right.
it's to convince them to come in.
Yeah, that's right. No matter what your duty is, in the end, I'm a human being.
Yeah.
And a lot of our communities had, perhaps the staff was vaccinated, but their family wasn't, because their family didn't believe in it, but they had to be vaccinated in order to show up for work and to continue to earn money. So there was that issue, like, I don't want to leave. We had, in the one location, they brought in trailers. So if somebody was afraid to go home, they could stay in a RV on site and provide care and sleep there and all that kind of stuff. So it was a wild
time.
yeah. And I was in those same presentations as you. That was the H1N1.
Yes.
Yeah, we had a lot more notice. And actually, it's so funny because that's what we talk about all of a sudden it didn't pan out the same way. We should have had the supplies. The H1N1 told us about shortages.
Yeah.
But yet somehow we decided that's where we were going to save money as a government, as individual organizations, that we weren't going to have that 3-month supply of products, masks, all that stuff. Yeah.
I'm like you. I remember sitting through those presentations, and the experts tell them exactly, these are the things you need to do to be ready.
That's right.
And then I'm afraid, sad as it is, people left those meetings and didn't do what they needed to do, so we were ready.
I agree. Yeah.
Now, the nice thing I do see about it now, if you go on the WorkSafe NB website, COVID, no, it's still with us, but they have a big, on their splash page, they have a big article saying, hey, yes, COVID is hopefully going to wind down over time, but think about the next pandemic. Develop your policies and procedures so that next time maybe we will be ready.
That's right. And 100%. I remember during the H1N1 presentation, everybody said, there's no way we can wear masks all the time. The residents will be terrified, all that kind of stuff. To me, and not that it's in place yet, but to me, I would like to see the nursing homes during flu season go automatic to medical masks on. Not the N95s, but the medical mask. Because the reality is, and this was what I was saying all during COVID, it's come in from the outside. One of you brought it in here. The residents aren't bringing it to you. Somebody brought it to the residents, kind of thing, and then it spreads. So it's quite the difference.
A couple of quick things I want to talk about. I'm sure time's winding down here again, but a couple of the innovative things you're doing that I find just fantastic. Virtual technology.
Yes.
Virtual reality, I guess, is a better way to put it.
Yeah.
Explain to folks what you're doing in that area.
Yes. So we do offer that. Well, we noticed during COVID we couldn't get to people. We couldn't get to a lot of people, but the hand washing was such an important part of infection control, and continues to be. It's number one. And we could do a hand audit, and at that moment, you're going to wash your hands just fine. But what happens when we walk away on the day-to-day basis? The squirts get shorter, the rubbing gets shorter, all that kind of stuff. So it really got our juices flowing about really that our workers were really restricted and needed on the front lines. So what could we do to bring education on a regular basis? So we did 2 VR modules so far. And then the process of looking for major funding to build a virtual library, because I think that's the key, that we'll just have a library. And then we feel that based on the current research, virtual reality is the way to go. So using VR is not unique. As you know, many post-secondary schools are starting to use them. What is unique about what we are building is that safety is no longer a siloed event. So it's not something I apply over top of what I'm already doing. When we're able to put it in the VR, this is going to be just the way the task is done. This is the procedure is completed with safety already incorporated, even down to the WMIS stuff. So in virtual reality, our first module we have is a hand washing module, like I talked about. The person dips their hand in mud, and then they're taken through the steps to wash their hands. And the idea is there's no more mud left on their hands. So if they've missed a spot, they'll still have mud on their hands. Now, our second module is about getting Mr. Smith ready for a doctor's visit.
Okay.
Which happens often. And often we force people to put on clothes and all that kind of stuff and get them up a lot quicker. So that's what the module is about, the gentle, persuasive approach kind of way in. But if I try to get into that room without washing my hands, because there's a virtual sanitizer just outside, it won't, the system's not going to let me in. And then if I use the hand sanitizer, but didn't do my hands properly, the system's not going to let me in. So now the system is allowing me to self-audit my bad habits that have come up over time. And we're really excited about it. And then instead of having, because first of all, it's hard to get anybody off the floor and replaced on the floor. But if I do a full day's training with you, I'm probably going to retain maybe 20% or a key thing. If I did virtual reality every day, every shift that I'm on for 10 minutes a day and worked on some skill, it's going to be harder for me to forget what I've learned. And adding safety to it is the exciting part.
Very good. Yeah. Now, last item I want to talk about, certainly not the least. You made a trip to Denmark.
Yes.
And that was extremely productive. Talk to us about that.
Yes. So what brought us to Denmark was sort of like what we were talking about, that we were looking for something different, something that was working. And in Denmark, they have a law. So the EU, the Europe in general, have a law that individual can't lift more than 25 kilograms. Denmark has that law, which is throughout the EU countries, but then added that you can only do that so much in a day. And then they added a law that stated if a piece of equipment existed to do that manual lift, that it was illegal for me to do that lift using my body, and it was against the worker and the employer, because often we have equipment and then they choose not to use it. They're not going to go and get it. So it's twofold. So we went to go see how that law works. But what was great about them adding that law, which I really feel North America should really adapt, I really do, was that it created an entire industry dedicated to inventing equipment to remove lifting, because they know if I invent this piece of equipment, they're required to use it.
That's right.
So it was quite something. So what we went there for was our new program, our new MSI All the Right Moves program, has eliminated all physical lifting except for at the bedside. So there's certain things we couldn't find a machine to do. So moving a resident from onto their side, let's say, to wash their back and stuff like that. Often when I'm sitting up in bed, I kind of, as a resident, I might slide down. We have slider sheets on there that make it easier to slide them. So those same slider sheets also make it easier for somebody to start slipping down. So I need to move them back up to the top of the bed kind of thing. We're doing that manually. So whether you're 450 pounds or 80 pounds, we're lifting and moving. So this new bed that was, well, I wouldn't even say new. It's been there for 20 years, believe it or not. We got to see it working on the front lines. It will eliminate that. So it's essentially 2 sheets on a roller. Mm-hmm. And then depending on, and you push a button and I can bring you to one side of the bed or the other side of the bed. I can roll you over. So even a simple task like putting on a sling would probably require you to walk back and forth on around a bed about 8 to 10 times. Just adjusting it on one side, then rolling it on the other side, then pulling me to the side, and going back and forth to get that sling in place before I can even use a ceiling lift. This would be a push of a button. So I would push a button to put you on your side. I would lay the sling on you, push the button, and you'd roll right into the sling. So it will be a game changer for our industry. And so 2 weeks ago, it arrived in Canada.
Very good.
It's at the University of Moncton, who, because of this whole Denmark project, has created an ergonomics lab for healthcare. So they'll test procedures, they'll test technology, they'll test equipment to see what the effects on the worker's body that has. And then they can kind of give their stamp of approval that, without this piece of equipment, this is the cumulative load. And that's the other thing too, is so many people use the median of load. So if you had a 400-pound resident and an 80-pound resident, they divide that by 2 and say that's the median. But what we're saying is it's not about the median, it's about the cumulative. It's 400 plus 80 plus another 125 plus. So they're going to measure how much of that load is offset by the equipment. So, yeah.
Now, for our audience, Denise sent me the link yesterday to this piece of equipment. And I've had a number of relatives over the years that have ended up, as they aged in nursing homes and so on. And I've often watched the nurses move them.
Right.
And I watched your video yesterday. What a slick piece of equipment. Very, very nice.
Yeah.
Very practical.
Yeah.
So, yes, I'm sure over time that's going to be a big assistant.
Yes.
There's so many, as you said earlier, so many injuries are tied into moving patients.
Yes, using my body to move another body, and we really have to stop it. Since our program, we've had anecdotal accounts of, we have workers coming up to us saying, I actually have energy at the end of the day. Yeah. Or 3 weeks after we started implementing these moves, we all of a sudden noticed I didn't have a sore back when I was going home. Yeah. So it's huge. And our work is also, there's sometimes it has nothing to do with an injury. I might be getting older and have arthritis as a nurse, and I have to end my career early because the work is so heavy for me to do. I will hurt myself if I continue on. If we can eliminate that, huge difference for everybody. We want them to go home. We don't want them to be couch potatoes. We want them to be able to enjoy their children, their loved ones at the end of a day.
Well, look, Denise, thank you very much for coming in. Very, very informative. For anyone listening to our podcast, again, we'd love you to have your feedback, whether it's about our podcast today or simply if you have an idea for a speaker, please send it off to us at podcast@ssnb.ca. And we'll continue to feature people like Denise, and we'll check back with Denise in a little while. And we're curious as to what's and how some of these things are going to work out.
Maybe we'll even take you to the lab.
Oh, I'd like to see that. Thank you very much.
Take care. Thank you.